Okay, good morning, everyone. Thanks for coming early. Good morning, everyone. We're going to call this meeting to order. Thanks for coming out early. First of all, we're going to pass around an attendance sheet just to save time for calling roll, and they'll be in the minutes. Number 2 is approval of June 17th, McLean County Behavioral Health Coordinating Council meeting minutes. What say you?
I have a
Motion.
correction. I have a correction.
Okay, thank you.
Page 3, first paragraph, Kathleen Taylor was from the Illinois Recovery Corps, CORPS, as opposed to court.
Got it. Thank you very much. We'll do note that. Anyone else? Do I have a motion to approve with the correction added? Motion by Member Reese, second by anyone? Member Hartman? Comments or questions or any other additions or corrections? Hearing none, all in favor, please say aye. Aye. And opposed? And the motion has passed. And we'll go on to item 3 on our agenda, the presentation from Statewide Behavioral Health Administrator Scott Block. Morning, Scott. I hope you're ready to go. We'll turn this over to you.
No. I think it's coming up.
Okay, we're up now. Okay, Mr. Block, we are up and you have the floor. Good morning, welcome.
From the court, and these are services that are available to all individuals, But the promise of the Intercept 0 and 1 services are that individuals receive the care that they need prior to ever reaching the court system. A couple of the things I really want to emphasize throughout Illinois right now are first being the Illinois helpline for opioids and other substances. And if you're not familiar with this, it's a 24/7 access point that is sponsored by DHS Super, and it can be used to navigate and access different levels of substance use care throughout the state. One of the enhancements of that program that just went into effect on September 1st is an expansion of a program which is called MAR Now, which is Medication Assisted Recovery Now. And what this is a program that was initially piloted in the Cook County area, and it is an opportunity for anyone seeking medication-assisted treatment services to call the helpline and within 24 hours be linked directly to a doctor that can prescribe one of the 3 opioid approved FDA drugs remotely, and the case manager that works directly with the doctor and the caller also has super funding available to them to assist with the actual purchase of those medications at a local pharmacy, as well as potential transportation to help individuals get to the pharmacy and obtain that medication. So this is something that we confirmed with DHS Super is available to individuals across the entire state and is part of their plan to continue fighting the opioid pandemic around the state. So that is an enhancement. But really the big happening here that you're all familiar with is 988, and I sit on the DHS Expert Consultant Advisory Committee, and 988, as we are aware, went into effect on July 16th, and at that point in time there was some misinformation and misunderstanding of what 988 actually is and is intended to do. And we believe there was a thought that many people felt we were just flipping a switch on July 16th and there would be a full response to crisis available throughout the entire state. And that is absolutely not true. I'd say in its simplest, all 988 did was moved the national lifeline number from a 10-digit calling number to a 3-digit number. At this point in time, the state has been tracking the success of this line, and we've already went from, I believe, a 17% response rate to callers when this was a national number to almost an 80% response rate. And that is due to the DHS DMH division contracting with 7 different providers as well as PATH services to be the responder to those phone calls. Now, the promise of 988 lies in the bigger picture of the 3-tiered approach of this continued crisis response, which is now being discussed as a 5-year journey. And 988 is the beginning of what we are talking about in terms of somewhere to call, someone to respond, and somewhere to go. So right now, the somewhere to call is 988, and this will eventually work hand in hand with CESA, the Community Emergency Services and Support Act, and I'll speak to that here just in a minute. The somewhere to someone to respond portion of 988 is still an infrastructure that's being built. DHS has now contracted with, I believe, 70 different teams that include mobile crisis responders throughout the state of Illinois, and they are working on connecting those teams directly to the 988 operators to be able to dispatch those individuals directly to individuals in need within the community when they need assistance. And then the somewhere to go portion of this is the most difficult to achieve, which has been started by DHS creating, I believe, 21 or 22 living rooms throughout the state. And living rooms are essentially non-institutional, non-hospital-like settings that are staffed by peer recovery specialists and individuals with lived experience. And these are supposed to emerge throughout the state as drop-off centers and opportunities to divert and deflect individuals from hospitals and institutions. I do believe the state is also working with a number of counties to try to increase crisis triage centers and crisis drop-off centers throughout the state. But again, this is something that is going to take at least 5 years to put in place. But in the big picture, this leads into the Community Emergency Services and Support Act, and CESA was an act that was signed into law by the governor, which essentially in its purest form requires a 911 operator to be able to determine whether an appropriate response to the caller is a law enforcement response, an EMT response, or a behavioral health response, or even some combination of those three. Some of the initial misinformation that's been stated around CESA is that law enforcement no longer had an ability to respond to these crisis situations. And there was a lot of, I'd say, misinformation and hyperbole around whether they were a piece of this puzzle. And law enforcement is absolutely still involved. There's direct language within the legislation that speaks to areas where they do not have a mobile crisis response service, that law enforcement is still the initial responder, but also language that allows the behavioral health provider to request law enforcement assistance and vice versa. So the way this is being implemented is by the Department of Human Services Division of Mental Health. There's an advisory committee that was directly appointed by the DHS secretary that includes individuals from 911 operators, the public service answering systems, the EMT systems, Department of Public Health, Illinois State Police, behavioral health providers, and so on and so forth. And this is the team that's guiding implementation. But then throughout the state of Illinois, there will be 11 different regional areas that have teams developed to put in place policies and procedures as to how their region will implement the pillars of this act based on resources that are available to them. So they will be deciding things such as response time, who calls who, points of contact, so on and so forth. And it's my understanding DHS is prepared to announce the individuals that will be on these regional advisory teams sometime within the next several weeks. These teams will all also be multidisciplinary and include everyone from law enforcement, first responders, 911 operators, behavioral health providers, so on and so forth. So I encourage you to, if you are not, to stay updated through the DHS 988 CESA implementation webpage, and make sure that you have individuals represented at these regional advisory committees, because this will be really where the rubber meets the road in deciding how this is going to work in your community. But this is also something that does not go into effect until January of this coming year. And I will just restate again that the legislation clearly states that if the infrastructure is not in place in your community, even as of January 1st, it's business as usual, and law enforcement still responds in the way that they responded prior to this legislation. So there are obviously a lot of policy and procedural level issues that need to be worked out, but in theory, 988 and 911 are supposed to work hand in hand at some point down the line and be able to immediately transfer calls back and forth to dispatchers in order to coordinate the response within the community. So again, that's why I say that this is a longer journey until we get there, but that is the intent of the CESA Act. Then we move into Intercept 2, which is primarily where the court gets involved. An individual now is penetrated further through the intercepts, and we have either the initial detention or initial court hearings. And I know that McLean County is not included in the initial footprint of the Office of Statewide Pretrial Services, which is bail reform, but we have been doing a significant amount of work throughout the state and essentially working with behavioral health providers to make them aware of what the pretrial Fairness Act includes and how this could potentially impact their services and systems. The one thing that I have cautioned most providers to be aware of, and I would ask the same of you and the providers in your community, is that in other parts of the country where bail reforms have been implemented, there has been evidence that shows an increased number of court-ordered substance use and or mental health evaluations after the act has gone into effect. So we are anticipating that in the first year to 18 months of the Pretrial Fairness Act, we will see more court-ordered substance use and mental health evaluations as the judiciary will be more cautious in who is being released into the community and will want more conditions placed on those individuals to ensure, obviously, that they appear at their next court date, but also to ensure as best we can public safety related issues and public health related concerns. So right now, the pretrial team is working directly with a number of regions throughout the state, and we have met with all of our behavioral health trade associations, as well as a number of the large regional providers to develop direct connections between the pretrial office and those treatment providers so that pretrial officers can help facilitate those referrals and get people connected as best we can. The intent certainly is always to try and lead someone to obtaining treatment and or evaluations on their own without a court order. And we are also working with the Harvard Government Accountability Lab to do some training for pretrial officers as well as the judiciary around how to motivate individuals to have self-motivation to receive care without court orders. So that work is currently underway in a number of regions throughout the state as well. You will certainly be hearing more about pretrial services and how it rolls out around the state. And again, the big picture is that there is an anticipation of about 20,000 individuals that will be under supervision through this new office in its first year. And the largest impact will be on our alcohol drug treatment systems, because one of the pillars of the act was reducing the number of charges that are eligible for pretrial detention. And at this point, there are no drug-related charges that are initially eligible for immediate detention, meaning on all of those, the state would have to file waivers and petitions for detention, and the court would have to find that there was a cause for that to happen. So we are anticipating a number of individuals will potentially be actively using substances at time of release into the community, which will be challenging for obviously the officers providing supervision and potentially our treatment systems. When we get to Intercept 3, I really want to speak to the Mental Health Inpatient Facility Access Act. This is an act that was again signed into legislation, which essentially requires the Department of Human Services to reimagine the state forensic hospital systems. We have roughly 1,100 hospital beds that are administered by the state throughout Illinois. Within those inpatient beds, we have felony offenders, misdemeanants, NGRI, and civil patients. And there's a national discussion and now a statewide discussion going around the idea of whether we are using those beds to the greatest effect and using those beds appropriately. We have to start looking at things within the court and within ourselves as to whether low-level misdemeanants that have non-serious crimes should be held in custody for competency and unfit to stand trial purposes. The court could be looking at the possibility of kind of tightening who is eligible for those types of services. The Supreme Court has a Justice and Mental Health Planning Commission that is going to start taking this entire system under their review over the course of the next several months, and we will be working closely with the Department of Human Services around this issue. To me, there is no one single solution on how we solve this logjam of the individuals that are held in local jails because of DHS's inability to transfer them within those statutory time limits into services that would regain their fitness, but we have to implement a number of solutions. Some of those have been DHS contracting with 16 different providers for outpatient competency and fitness services. We're looking at court taking more control of case management within these services, and certainly whether some of the NGRI patients that are still held in those state facilities and whether some of the misdemeanants should be held there, or whether we can start looking at outpatient and community-based alternatives. This, again, is not a singular issue to Illinois, but a conversation that's happening at the Conference of Chief Justices and across the country. The final couple things I would like to mention is the emerging Illinois Opioid Remediation Advisory Board. This is direct from the statewide opioid settlement. Illinois will be receiving somewhere in the range of $760 million for opioid remediation over the next 15 to 16 years. The way the allocations of those dollars will be decided, again, is directly by an appointed board of advisory members that will be working directly with the governor's office and the new chief behavioral health officer. It's my understanding that that board will provide recommendations to programming and services that will be implemented and carried out throughout the state, again, for purposes of increasing access to opioid-related treatment services and also reducing opioid overdose deaths. And then in the youth world, there is what is called the Children's Behavioral Health Transformation Initiative, which was, again, an initiative led by the governor's office, and appointed Dr. Weiner from Chapin Hall to meet directly with all of the funders of juvenile and youth services, including the State Board of Education, Department of Juvenile Justice, HFS, DHS, and DCFS, and look at opportunities to coordinate services more effectively, reduce policy barriers to youth accessing care, and even repurpose dollars to focus on emerging and more urgent needs. There's supposed to be a report that comes out from this effort at the end of the year with a series of recommendations. From the court perspective, we did have Dr. Weiner meet with about 30 or 40 judges to get their insight into what they felt were the areas in most need of change within the youth and juvenile behavioral health systems. So there has been some direct court input into the services that are being developed and the recommendations that will be coming out of that effort. And then the final thing I would like to speak to is the work of the Mental Health Task Force. Just this July, we hosted the Conference of Chief Justices and State Court Administrators in Chicago. And at that conference, that group approved a resolution which essentially encouraged all courts around the entire country to lead, examine, advocate, and educate around justice and behavioral health issues. This was extremely significant because the resolution was, again, approved by every chief justice throughout the entire country. And the next step of that will really lead into the work of our Illinois Mental Health Task Force, which is about to release an action plan within the next several months. And we will be encouraging courts as conveners at the national level and state level. The recommendation is to develop local, judicially led multidisciplinary teams to start looking at the entire sequential intercept model and developing new solutions that meet their community's needs. So I did take a look at McLean County, and I'm aware that you have a criminal justice coordinating council as well as a behavioral health coordinating council. And this idea as courts as conveners to look at the entire sequential intercept provides you an opportunity, I think, to bridge those two groups together and lead discussion with those individuals that can actually influence policy. I often use the reference of Miami-Dade County Judge Leifman, who is a champion of this work. He will tell you that he convened the local sheriff, corrections office, behavioral health provider, hospital systems for 10 plus years before he was able to initiate some change. And then 10 more years went by to get to where they are today. So the idea is a regular meeting with those that influence policy and resources on a regular cadence that continues to look at opportunities to improve. So we will be, again, hopefully promoting that throughout the state, and I will be available to offer technical assistance to those areas that need assistance in doing that work. Obviously, you guys are well ahead of a number of other counties throughout the state. We will also be reconvening our regional councils on a quarterly basis to learn from one another's throughout the state of Illinois about different solutions, opportunities that are being in place, keep people informed of everything that's happening with all those other programs that I just discussed, 988, CESA, bail reform, MAR now, opioid settlement, so on and so forth. So right now, there is a lot of opportunity to reshape behavioral health and justice systems, and these are certainly just a few of those things for consideration. And with that, I will just make sure that Kevin has all of my information, and as you move forward, I am happy to keep you informed of work that's happening at the state level that could influence your local discussions, and or continue to work alongside of your groups to assist in any way that I can from that court voice and perspective. So again, I thank you for the opportunity to be here. Sorry that I could not be here in person, and look forward to our continued relationship.
Thank you, Scott. I guess if you would wait just a second, do we have questions from anyone? I don't know if you can hear or not. Well, thank you very much. We appreciate all the information and the amount of change that you're providing. So take care.
Thank you, Scott.
Thank you. Well, let's move on to item B on our agenda, presentation from Tri-West McLean County Behavioral Health Crisis System Analysis. And so I'd like to again welcome Jesse Seeger-Walls. Got the hyphen in there this time. And welcome back, and we look forward to hearing what you have to say.
Great, thank you, Chairman. Can you all hear me? And I'd like to know if my colleagues that are joining me through not telehealth, but are we on Zoom or GoToMeeting? I'm joined by my colleagues Sam Shore, Lisa Tamaka, and Kelsey Urdia. For stakeholders that aren't as familiar, it's been a while since I've visited you last, and we were introduced to you all through an opportunity that Chestnut offered through some grant funds that were focused on enhancing crisis services in the community. And when we approached them with ideas of how we could spend some evaluation dollars, assessment dollars, they said that, we think it would be better spent if it was done in the community setting with the BHCC. And so we spoke with the county administrator and at the time the director of behavioral health coordination, and we gave a list of ideas of things that we thought might be helpful, and then we came to this body, shared those, and came to the point that we think examination of the volume and flow, mapping the current system, looking at the monetization of that system to see are there areas for enhancement. So I want to start by saying thank you to the stakeholders that were participating. We have a great amount of gratitude for the candor that was shared during this process. A special thanks to the Director of Behavioral Health Coordination and your predecessor, Vanessa and Taylor Davis. Thank you very much. Our counterparts were instrumental in making sure that we had timely access to interviews, scheduling, focus groups, getting quantitative data from stakeholders. So thank you very much. We can advance the slide. And I'm sorry, could you remind me your name? So, Dan, thank you very much. So today, this is opportunity for us to do an overview of this report. I believe you all have a copy of it and had been opportunity to start reviewing it. I don't expect that you've all read it. But when we work with communities, this is our initial feedback opportunity. So sometimes people do reports and they're final. We look at our reports in developing crisis systems as a conversation. And so we expect this report to be a conversation starter. There may be things that you see in here and say, you know, it's not quite accurate, or the characterization is not quite right. We want to hear that feedback, whether it's today or you follow up via email or over time. We know that there's going to be little aspects of truing the wheel even more so that this is the most useful document possible. So we're going to talk a little bit about the scope and methods that we used. Talk about what do we mean by an ideal system? What lens have we brought with us to look at the components of the crisis system? And when we say crisis system, we're really looking at that intercept zero that Scott was talking about, taking that crisis continuum, kind of blowing that section up and looking more carefully at those components. We want to review local behavioral health needs. How much need do we have in the community? Review current system utilization, give an example of an alternative system, and provide overview of considerations. Now we use considerations intently here instead of recommendations. If you've started reading the report, we talk about the need for an accountable entity that is able to make major decisions and really monitor the system and think thoughtfully about it. We don't have all that knowledge that's necessary to make hard recommendations. We're using a lens and frameworks of what we've seen nationally, but there's political factors, social factors, financial factors, quality of care factors that are beyond our understanding to be able to just glean in a couple weeks of interviews. And so we produce this report in an intention that those conversations of what's realistic, all these considerations need risk assessment. You know, what changes are feasible? What changes are practical? Dan, would you advance? Yeah, thank you, Dan. So what is an ideal system? We draw upon the group for the advancement of psychiatry, who produced a roadmap for the ideal system of crisis services, and then SAMHSA's recommendations for ideal guidelines. In this, they have oversight and governance, crisis continuum, which includes what SAMHSA refers as the key components, which someone to call, someone to talk to or call, someone to respond, and a place to go. And then best clinical practices. The oversight and governance, this is the high-level structures of who's accountable for monitoring the system. Looking at performance incentives, looking at customer satisfaction, including not only the individuals that are contacting in need of services, but first responders, seeing them as a primary customer in the crisis continuum. What is the flow and throughout? What is the level of data sharing and utilization of management and planning? Crisis continuum, not only are those key components, but what is the staffing and volume associated at each of those key phases of the continuum? And to what degree are they responsive to special populations? Ideally, is the system serving people of all ages? Is it serving people of all clinical characteristics? Is it attending to special populations like veterans? And then basic clinical practice is looking at, you know, the engagement and assessment at each component, at each node within the system. Are they doing best practices, implementing best practices? Are they having best practice guidelines in relation to how they're connecting with other points in the system? Is there a shared vision for this clinical practice that we have an idea across this body of what the experience would be like to enter into the behavioral health system, both from the point of the person entering that needs services and different points, again, first responders, or whether I'm ED staff, or whether I'm mobile crisis staff. Do we all have a shared vision of what those experiences of those staff members? We're in a behavioral health workforce crisis. right? And so we have to attend even more to, are we designing a system that is going to make it viable to have people want to work in our system? And again, best clinical practices is going to look for the continuity care and other key aspects of that might be unique to each node within the system, like peer support. Where is peer support best utilized? Is there areas that we could enhance and incorporate more peer services? So we use what's called mixed methods. We have quantitative and qualitative data. We did a site visit that kicked off more than 40 hours of key informant interviews. We met with over 30 community stakeholders. And then we also had a public session available to the community. That was invitation that went out to anybody that wanted to participate. We got a lot of consumers that were participating in that focus group. And then we were looking at the quantitative data. That was one of the kind of the primary goals, was to get hard numbers from agencies. And sometimes we weren't able to get good data, as far as it was a struggle, or we didn't have enough time for agencies or different system components to provide comprehensive data. And so sometimes we had to make estimation, and we'd follow up with, based on what you've given us part of a year, for example. Do you think it's fair for us to estimate X? Or, you know, based on what we've seen elsewhere, do you think this is a reasonable estimate or approximation to make based on your 911 calls? For instance, we used the breakouts of age groups at the mobile crisis for the 911 encounters. We don't have a good breakout of what age groups are encountering 911, right? So here we make an approximation. So when we use data in here, we start rounding numbers when you see the utilization flow. That's intentional because not all the numbers do we have quality data, and then not all the numbers add up. Why don't they add up? Well, we might go to mobile crisis and they might say, well, we had XYZ come from another agency, or we sent them to ED, and then the ED says something different, right? They're not dramatically different, but there's small differences. That's another indication that the need for continuity in information sharing, so that our numbers all add up at the end, and we know where people are coming from and where people are going. Great. Next slide. So this is a table that starts talking about, well, how much need do we have in our behavioral health system? Now, the NAASP, which is an I'm forgetting. Sam, can you help me with the acronym? I'm forgetting the full acronym now. Oh, maybe Sam's not on. Great. Well, you may have heard of Crisis Now, and it's another planning tool that's out there, and they estimate that 230 people per month need behavioral health services per 100,000. Well, that figure isn't really fleshed out very well. It doesn't have a strong definition. It doesn't say how many are children and adults. It doesn't say exactly whether those are just EDs or whether those are people that are contacting 988 or 211. We found that it's an underestimate. So we wanted to show here, so on the low end, you have the NAASP estimate. Then we looked at, Carl has their community dashboard, and so we looked at the data that they were presenting on just ED visits. And so here you'll find that they suicide and mental health ED visits captured some of it, 7,000, a little over 7,000 per year in McLean County. But when we started looking at the data and counting the people that are contacting PATH, counting the people that are walking in or encountering mobile crisis, counting the people that are walking into ED, we observed closer to 11,000, over 11,000 to 12,000 people in a year contacting, touching the behavioral health system. So the next diagram is a conceptual flow, a more aesthetically pleasing pro of what we see occurring in the adult system in McLean County. We have this blue segment here because over 60% of ED encounters are someone's arriving to the ED and then they're calling mobile crisis. And so instead of mobile crisis encountering people in the community, we've already had an ED visit, and now it's now we're some people would say going upstream a little bit to now bringing in crisis, mobile crisis. At the bottom here, you can see the resolve rates. Crisis line, that is comparable to what you see nationally, and kind of good practice, very high resolve rates before it goes on further into the system. 54% being resolved through mobile crisis, but and then when the emergency, part of those are at the emergency room, so we don't have a great understanding of to how many are truly unresolved that are just mobile crisis in the ED or get resolved before mobile crisis gets involved, and how many are resolved. So it's somewhere between 0 and 52% are getting resolved at the ED before any other point of encounter in the system. And then we have two disconnected items here, or nodes, which is the triage center and crisis residential unit. Now, some of you may say, well, crisis residential is not open right now. We did this based on the system that you guys had planned. It was planned for crisis residential, so we used data that was available of crisis residential to simulate what the system might look like in a recent year if it was online. And then inpatient visits, and half of those inpatient visits are occurring here locally at Carl, and a little over half are going out of the community. And children. Lisa, do you want to describe the child and youth crisis system?
You're still muted. You're still muted.
Thank you, Sam. I actually was saying, oh, good, there's no echo. Well, there's no echo because I was muted. So I think what's really interesting about the children's crisis services is Jesse, this might be better if you did it, because it's really hard to.
Great, will do. Okay. So a similar, except we have a similar diagram as far as the flow goes. You'll see Project Oz and Crisis Nursery. We wanted to make sure that those were highlighted because because there is not a triage center for children and youth, because there is not inpatient beds for children and youth, they have to do a lot of work of prevention within their own agency, having their own crisis call response and having a number for people to call and doing a lot of preventative to make sure it doesn't escalate. But although they're not formally tied into flow in the crisis system, we wanted to acknowledge that they're doing a tremendous amount of work of preventing, and they have their own internal crisis response guidelines and protocols that are helping the community. Here the resolve rates are a little bit lower with the crisis line. Now, PATH it's a small segment of what's coming through PATH for children and youth. Most is coming through the CARES line, and there's tremendous difficulties with this. And many of you may already know, but the long wait times. I mean, we heard, appalling to me that a nurse would need to tie a cell phone to her ear while she's working and for 2 hours so that she could wait to get connected to the CARES line so that she can get mobile crisis. or a doctor having to just sit at his desk and leave it on hold for over an hour so that they can get connected to the CARES line. And so we understand that you all don't have complete control over the CARES line, but this might be an opportunity to further advocate at the state that this needs to be fixed to get timely responses and services to children and youth in the community. I'd say, Lisa, if you had anything else, but I'll just take your silence as assume I'm characterizing it in the way that you would want me to. So we also, all the inpatient beds, as you know, are occurring outside the community. There's not capacity here in McLean County at this time. Great. So this is a flow diagram of utilizing actual data. And so what you can see here is triage and crisis residential representing a very, very small aspect. And what we would want to see is strong referral lines going there. But most are going either go to mobile crisis or they go to ED. And a lot of calls that go to police or go unresolved. We don't know what happens after they've encountered. They don't get connected to ongoing services. As I said earlier, a lot of the local need for inpatient care goes out of the community, where people have to then travel farther, right, and further away from their families to be able to provide support for their loved ones. And sometimes it's just not feasible for them to do that. Ideally, that they would stay here in the community. So at each point in the node, we got an estimate. Either we would get an estimate from a provider or an organization locally here, or we would use what we found as a comparable national rate. And applying those costs into the adult and child systems, the adult system is costing somewhere around $25 million per year, and the children's system is costing somewhere around $7 million. Again, we don't know how much of that child need is being responded to by organizations like Baby Folds or Project Oz. It could be higher if there was a line of services available. So if you start opening up lines of services for children and youth, they're going to utilize them, so the costs will go up. And so we think that these figures are associated with a little between 11,000 to 12,000 encounters, and then between 20 to 25,000 points across the system in total. So this is an example of an alternative. It's not, and we wouldn't even say this is what your system has to look like. We're saying that this is what we've done now is done an exercise that we would think the accountable entity would need to refine and go through similar steps. We need to collect data and start to project, simulate what a more efficient system would look like. Here we see strong referral lines into triage. Triage being closely connected to CRU for people that need a higher level of care being transitioned to CRU. And then for a small segment, people being transitioned from CRU to local inpatient. We have far fewer lines going directly into ED, and then we also have ED deferring into triage, deferring into crisis res based on the appropriate level of care needed there. And then we have also PATH being a direct referral into triage. These were difficulties, and so I just want to take a moment and talk about triage and CRU. We call them throughout the report, these are non-ED receiving centers. They had a lot in common. They both started at the point of COVID starting. It's not an ideal time to launch a brand new segment of your system. There's no way you could have planned for that, or they could have planned for that. Still, there was there are other factors that they shared. Lack of community awareness. Where is a triage center? How do I get there? How does people get transported there? Why would I go there? In what circumstances would I choose that place? Oh, you don't take 17-year-olds. Okay, now what do I need to do with my 17-year-old? Lack of transport. So there was never a strong referral line established between ED and either of these centers. In our experience, that has to be established, that there has to be a strong relationship between ED knowing this is an option when someone presents. If our ED, if this person could be better served in these settings, how do I get them there? Maybe it's an outreach van. Maybe it's the ED center sometimes pays for taxi service or Uber or Lyft services to get them there. Sometimes the sobering centers or triage centers or sobering centers, they handle all the transport and make it. They just say the ED needs to call them and they'll send a van or a taxi there to get them there. Neither of these were established for triage or crisis residential. There was no evaluation implementation. And what I mean is these programs oftentimes benefit from a strong evaluation where we're tracking what are the elements of flow, how are people coming into the center, what are the characteristics of the people that are encountering at that center, what is the experience of the referrals, what's the experience of the ED coming in, is it easy for them, is it close to a warm handoff? What's the experience of the first responders utilizing the centers? These need to be high. The first responders, if you have a couple instances where it's taking them really long or it's a difficult exchange, they're not going to be incentivized to utilize that service line. And it only takes a couple times of having a very bad experience until it catches on and by ear, and nobody, even if they've used it or not, will want to take the initiative to transport people there. So an evaluation would typically track these and monitor these satisfaction elements and the flow and volume, monthly flow. And so we evaluate programs in the country where every month we have a dashboard. And so the stakeholders can see each month, okay, how's it going? Are we getting the referrals we'd expect? Are people being referred out to the communities and tracking referrals back into ongoing services? Workforce challenges. Both the crisis residential and the triage center experienced a lot of turnover. Again, I mentioned earlier, we all know that we're in a workforce crisis, and that's not a surprise there, but it was encountered for both these organizations. There were some characteristics that were unique to both as well. As I said before, location is difficult for the triage center where it is now. A lot of people don't know how to get there. And it was tied along with that community awareness. Like, oh, I've heard of it, but I don't know where it is, or how to get people there in a timely fashion. The hours had changed, and so people were not quite sure. Well, even if I access there, will I get there in time to use those services? Secondary transports. Crisis residential experienced some secondary transports meaning people after they had come to crisis residential were then transported to ED. And so these are an indicator that there's need for either not the right people are going to there in the first place, or there was an experience there that escalated and then they needed to either go to jail or they needed to go to the ED. This is, again, these types of things are tracked in an implementation evaluation. So as soon as there is a occurrence, there's a root cause analysis of could that secondary transfer have been prevented? And now we know that there's always going to be some that are unavoidable, but if there's a high number, then it's going to further cause first responders not to want to take people there because they don't want to be called back and have to transport them to ED again or to jail. And then there's community perceptions of the quality of services at Chestnut in the crisis residential. Now we didn't have the ability to verify, or we didn't do root cause analysis of what they were, but those perceptions are out there. And even if those, and since those perceptions are out there, those have to be, negotiated and talked about. And for this body to work as a team, or the community to work as a team, is like, okay, let's analyze what were the facts of the care. Are there ways to improve services, or are there ways in which other people encountered crisis residential that can be mitigated and work out those relationships? Dan, can you go to the next slide? So here's an alternative system. So taking those, for the adult system, that is, taking those 11,600 encounters, if we boosted key aspects of the system, this is a projection of what we would expect to see encounters in an alternative system. In the report, you'll see a bulleted list of all the assumptions we made along the way of improving triage, bringing crisis residential back online, having close and effective PATH and 988 implementation. If that's effective, we would expect to see fewer 911 calls. So we adjusted 911 calls down. We also assumed better improvement of people moving into non-ED receiving centers. We're going to also decrease demand on inpatient. Ideally, everybody would be served in McLean County and not have to be transported out. So using the same cost estimates we had for the current system, we think, there could be a dramatic decrease in the overall cost of the system. Now, this figure is not intended for budgeting. This is a simulation that's intended for ongoing planning. And so this is more of a vision statement than operational. Okay, we only need to get 13 million together or appropriate funds accordingly to this come again, this is an exercise that we hope that will be useful for this body and any other structures that come out of this, to start repeating this and refining it. And during those conversations, we can come in and say, hey, here's all the costs, and just show line by line what these estimates are. Some of the cost reductions are going to be because the triage center is a fixed cost, right? You have to employ people to be there the entire time to receive people. If you only receive one person in the day, they are accountable for that full cost of the day. If you increase volume, you're going to have a unit cost that's appropriate, which is around $100 to $200 per encounter. And the volume that the triage center has experienced to the date that they provided data for us was much higher, and you'll see in the report it's closer to 2,000. And that's mostly all just due to not having 7 to 8 people there per day, which would be a volume we would expect in McLean County. Great. Oh, this is too tiny for you. It might be too tiny for people in the back to read. So we have these considerations. I told you why we haven't termed them recommendations. Still, we wanted to further classify them as developmental, transitional, or transformational. And there's a little key in there that describes what we mean by those. But in short, developmental are things that you might think of as quick wins. It might be additional training. A while back, you had the community had CIT training for almost all the officers. Well, that's due to officer turnover, and they don't know how many have CIT training. It could be half. When we met with them, they honestly didn't know. So one thing is, training up, making it routine training for all officers, having booster sessions, That's an example of a developmental improvement. It doesn't take a lot of resources, and it's not a complex change. Transitional changes are things that take longer and takes more planning and can be threatening to some stakeholders sometimes, depending on what the change is. So establishing formal partnerships with the non-ED receiving centers, right? This would be a fundamental change that would make, we're going to have formal partnerships, MOUs, MOUs and MOAs, and make hard commitments to one another of how we're going to interact and coordinate. And there might be financing involved in those relationships. These are transitional from going from, again, mobile crisis going into the ED after someone's already entered to having formal partnerships with the non-receiving centers. And then transformational, these are the most difficult, and this time takes longer because it takes multiple stakeholders to negotiate what those changes would be. In this report, we say one consideration is having a formal accountability, governing accountability entity. We don't, again, know all the factors of how that would best look here. But we would encourage this body to think about what would it look like for us to have a accountable entity that can have conversations at the management level as well as the executive level. We know that sometimes this body here is prevented from meeting to coordinate because of open meeting requirements, right? Well, is it going to be in violation if you have managers working together to do the same as representatives? We don't know. This is something for you all to determine, but to move the crisis system forward, we think we really need to have a governing structure where they can meet, be more nimble to make changes and build relationships where you need to. So I'm going to briefly go down these considerations and provide light commentary along the way, but more explanations are provided in the report. Conduct a comprehensive self-assessment and develop a system enhancement plan. We didn't do a comprehensive assessment. We really focused on volume and utilization, and then we did the qualitative to really understand the proper mapping of the system. But along the way, we heard themes that were related to these big categories of an ideal system: oversight and governance, continuum of care, and best practices. And so we weren't going to leave those on the drafting floor because these are important findings that we wanted to bring to you all. A self-assessment would be comprehensively taking findings from this report would already be a big step forward in completing that assessment. But going through something like the roadmap that I described before, they have a self-assessment that could be used to do a comprehensive view and more granular view. Establish a formal coordination partnership throughout the system, moving to real-time air traffic control. And what I mean is the idea that just like bringing in airplanes to the airport, we would be able to track someone moving through the crisis system here. And every point would know, okay, what is their status? How long are they waiting there? Okay, they're in crisis res, but they're having difficulty. Now they need to move to ED. The ED can see that there might be some people coming, that there might be needs coming from the crisis res. Again, this is ideal systems, and they are out there. They're in Travis County. Sam knows some of the other ones off the top of his head of where these types of settings occur, but we can provide more examples of this high continuity level of coordination can occur. This would take a lot of effort to implement. Establish a formal referral partnership between the ED centers, non-ED centers, I've talked about that. Reconcile regions and jurisdictions to improve coordination. We didn't do a deep dive, but we know that there are lots of overlapping but not perfectly aligned service regions. This is something that through a comprehensive assessment could bolster the ability to make sure that the continuity of care is consistent across the system. Dan, would you go to the next slide? Transition towards a central card center that can respond to behavioral health crisis regardless of age and insurance. This is a little bit outside, well, some of this is outside your control as far as Medicaid requirements for children and youth. This is a big barrier. So if I'm a family in need of crisis services, which insurance I have determines how long I'm going to wait for care. And I don't know to what degree this body has ability to find a workaround for that, but it's needed. I shouldn't have, because of my insurance status, I shouldn't have to wait 2 or 3 hours longer to get care. Strengthen non-ED centers. So we have a number of considerations here. And that's why we've spanned them, that there's developmental, transitional, and transformational ones here. Co-locate the triage center with ongoing services. It currently is on an island by itself, not connected to a full array of services. Other places we see receiving centers like this are connected with behavioral health centers, and where there's lots of quick access to ongoing services or additional crisis services or urgent care levels services. The fact that they're located off on at where it's located now, again, also leads to difficulty accessing it. It's not a common place for most people to look for behavioral health care. Expand the triage center services to children, youth, and families, and sobering services for adults. Here again is, ideally there's a place just like a triage center for adults that families can come. And it's not always about someone having a first episode psychosis. It's sometimes, I'm about to get evicted and there's other support services that need to be involved to help this not escalate into a bigger crisis, and that or trauma when parents are having domestic violence issues, that there can be opportunities for the children to be seen and supported in traumatic situations. We also talk about sobering services for adults. Oh, I just want to say about with the children's services, we do see models where they're at the same facility, where they have 2 branches and are able to utilize staff to service both the children and adults. There is a division, right? There's not an expectation that all the adults are being served with the children and youth, but there's kind of 2 sides to enter the building so that care can be separated. Sobering services. Currently, McLean doesn't have sobering services. This is leading. You're starting to see them pop up all over the country now as safe places for people to sober, then get connected to ongoing services. Sometimes they don't. Sometimes it is. There's a baseball game and someone had too much to drink. But instead of being publicly intoxicated, this is a safe place. They're not left out by their friends in the cold. But it is oftentimes a part for high utilizers that are chronically inebriated to have a safe place where they can sober up and then be directly connected to care. People in the community that I was interviewing, I was sharing that we are evaluating one in St. Louis that has been tremendously successful in their first 6 months, outperforming a lot of their counterparts in other parts of the country. I think in part because of the careful attention to their implementation evaluation, but it's very well received. And this community is going to need it because of the Safety Act is going to require that fewer people are jailed due to inebriation. Where are they going to go? More people into the ED? Possibly. If this is the importance of having a sobering center in McLean County, or extending triage services to include sobering services if that's feasible. Based on our interviews, there could be 25 people per day, 25 to 50 people per day that are currently right now in the jail for for behavioral health needs that are going to be in the community. And so making a plan for what would it look like for sobering services could be a major value add to the community. Reestablish CRU. Clearly, we kept them in this model all the way, even though they're offline. We think that wherever it's located, that level of care needs to be reestablished to fill out the continuum of care. It's recognized as best practice. Almost, I haven't seen any recommendations that don't include that level of care in a community for a behavioral health system serving the population of McLean County. Conduct an implementation evaluation again. Examine clinical workflows to transition to fewer ED-based model of mobile crisis responses. So some of these recommendations are put in there independent of all the other considerations. But even if triage center doesn't get bolstered, even if crude CRU doesn't come back online, trying to identify how can we have mobile crisis coming in earlier? How can the ED, how can PATH, how can we identify opportunities to connect people with mobile crisis before they end up in the ED? Next slide, please, Dan. Conduct a systematic review of best practices. This goes into that third element of the ideal framework that we didn't spend a lot of time focusing on. But one of those activities would be, are we implementing best practices at each point in the system? This is where this consideration is pointing to. Establish a crisis training initiative for all health professionals across the system. This is we heard from the ED, you know, sometimes they would get really great care. Sometimes they would have care that frankly, some of the consumers we talked to resented, felt that they were not treated humanely. And because of that, we know that Carl is even implementing more behavioral health nursing staff. And that is tremendously valuable to have people that are trained and specialized. Still, across the system, and just like with CIT, it's not enough to have one or two people specially trained. There has to be core competencies, regardless whether they're on vacation or that they're busy with another client, that everybody has core competencies at each point, that people can have an expectation that I'm going to be treated well in a welcoming manner. I'm going to be treated with respect, and I'm going to have a person-centered orientation. So the idea here would be a crisis training that the system would take stock. What does our competencies look across all the nodes? Is there ways we can collaboratively improve it? Maybe there's trainings that multiple agencies can all participate in, so that's not, the training burden isn't just on one organization. Finance standard CIT training and periodic boosters for law enforcement, and revise the non-ED receiving center eligibility. This is one of the barriers. We heard first responders saying, I can't take anybody, law enforcement, I can't take anybody to CRU or triage center. They have a history of violence, right? That's one of the criteria. History of, well, what does that mean? Well, yeah, they had a assault charge 5 years ago. I guess I can't take them to the triage center. That was the interpretation of many of the first responders, and so they automatically would take them to the ED or jail. So all the non-receiving centers need adequate eligibility criteria where people that can be assessed in that moment what is the level of violence risk at that moment. So this is just an example of revisiting the eligibility criteria so that it's not excluding people that would be appropriate for the care. And if there is concern that we can't handle a call, we need to reassess, hey, do we need more training? How can we make our setting more welcoming and appropriate for people in the community before resulting in ED or jail? Okay, thank you. I know I've taken a long time. I know that there's another item on the agenda, But I also, again, want to say thank you to everyone that participated. We look forward to hearing your feedback. And thank you for our time.
Thanks, Jesse.
Thanks, Jesse. Do we have any questions? Thank you
Is there
very
time for questions, Mr. Chairman, or do we need to move forward? I don't know if you,
Let's go ahead and take a couple questions and
All
we'll
right.
move forward.
well, thanks, Jesse. This was outstanding, data. I was just wondering your thoughts around, we now have, if CRU reopened, we have different organizations providing different services. And is there a structure to bring those organizations together to be one team? And you use the term co-location is important. Can we somehow create a structure? And I know this would be transformational, not developmental, almost a behavioral health urgent care center, if you will, collapsing all of these services into one. That's my first question. My second is, you didn't bring up the importance of including psychiatric prescribing in here and linkage to medication-assisted treatment as part of the sobering center. And I wanted to get your thoughts on that too.
Great. For the co-location, there are urgent centers out there. We didn't have enough information about the political and the practical implications of whether that could be established here. And we're not saying that it couldn't. And if you asked me right now and said, is that a good idea? It sounds like a good idea to me. We see it at Traverse City. I know there's one that's just started up in Kansas City of a comprehensive behavioral health center. We didn't put it in there. That is a big lift, like you said. It's transformational to the degree that we would support it if that's what this body thought was practical. But we don't know enough about those factors and would encourage this body to further explore that opportunity. To the psychiatric need, yeah, I think we could revisit the report and further emphasize, the fact that this community needs more psychiatrists. That was universal. And, part of us, we left some things out just like that, like we need pediatric psychiatry. Everybody knows that in this community. And we had people are really struggling to get access. I think it'd be valuable for us to make more attention to that. In regards to MAT, we see sobering centers independent and that they're closely connected to detox, they're closely connected to ongoing outpatient and intensive outpatient. I haven't seen so much MAT in, apart from Suboxone and stuff like emergent stuff, but ongoing, starting with MAT usually starts after someone comes to the sobering center and is connected to services. Dave, is that answer your question? Okay.
Okay. Judge Rob?
So what do you recommend?
We'll come to you next. Daphne, hang on.
What do you recommend this body do next?
I think you need to determine the accountable entity. How does this body want to take accountability for the crisis system in a more formal way, in addition to your current charter? And outlined in this report is that means a staff member that's going to be associated with whether it's your coordinator here or someone else, regardless of where that entity lives. It needs to be the convener of all the important elements and have the ability to nimbly meet, to plan, to implement, and respond. Maybe that accountability is the BHCC. Maybe it's a work group or a sub-tier that has multiple work groups. In the report, we talk about a lot of the work groups that are needed, right? You need a clinical work group, and then you need a sustainability work group, and people that are keeping their eye on multiple aspects. It's a big lift, and this is a system of care. It's not a full system of care. This is just a crisis system that requires the same level of participation and commitment to have people routinely come to the table and participate, I would say, full-throatedly and with full effort. So, long-winded way of saying, yeah, the organizational structure for your accountability entity is what I think is first needed.
Well, with governance and accountability and authority also comes authority. You have to have that, and you have to have ways to do it. We have a voluntary organization in a lot of ways, from what I'm reading through what you've talked about with contracts. So we need to, you talk about transformational, that is a big issue on how do we do that? I mean, this is a great group of folks. They all represent organizations, they all commit, but if they don't, it's a voluntary commitment, and that's what we have here for a group. So along with governance comes government, comes authority. You agree with that?
Yeah, I mean, you're going to have a body that has the authority to make implementations and make real changes and have high expectations.
We've got time for one more question. Stephanie, you're on the screen over here. Jesse, right here. Jesse?
Good morning, everybody. So I have one question, but I also have a couple of just clarifying pieces. I think it's important to note that especially for youth, the ED visit rate is much higher in 2021 than pre-pandemic because COVID has required a number of those youth to have to go through the ED prior to any kind of follow-up care, whether that's an inpatient admission or something else, because of the requirement for immediate COVID testing. So I do think that that is an area where we need to continue to work on, educating the community that that's not necessary and moving back out of the EDs and back into the community as much as possible. I have one clarifying statement on the report where I found an inaccuracy. On page 46 in the crisis continuum consideration section, the green box, it actually states that SAS does not receive reimbursement for cases assessed and dispatched by the CARES line, and that's actually completely opposite. We only receive reimbursement for calls that are assessed and dispatched by the CARES line. And then my question, so Jesse, I noted the feedback on the CARES line. It's something that we have been advocating around and communicating with the state and the agency responsible for that line for a number of years. Relatively recently, they have changed to a new system, and our experience has improved. So I guess part of my question in that area is, how do we have a sense of how far in the past that anecdotal report may have been coming from, or were those recent experiences that we need to be focusing on advocating again?
Thank you, Stephanie. And thank you for finding that technical edit, because our finding right now, Lisa would agree, that's our understanding, and perhaps through our final editorial review, the verbiage of that sentence was restructured incorrectly. Thank you for that clarification. We're going to make that change in the report. For the CARES line, they spoke to us as though these were the current issues. And when we asked, what are the pinch points right now? These are the things that came up. And so I don't have a ability to tell you this happened 4 months ago, 5 months ago, 2 years or 5 years ago. But your point is well taken. I want to include that in the revision of the report, that clarification that there has been improvements, also about the aspects of the need for COVID testing related to initiation of these calls, or in the process of responding to these calls. Thank you very much.
Okay, thank you, Jesse. Thanks for the great report and all the effort, what you've done with your group of people, and thanks for the initiation of that from Chestnut and bringing them here. So that's an eye opener for us. It's good to have a self-evaluation.
Mr. Chairman, just quickly, is there a time frame for feedback on this draft version? Are we looking for that as?
Would a week or two be?
Yeah. If there was, and if you're anticipating it from this group, your opening remarks kind of insinuated that's an opportunity. Great, thank you.
Just, excuse me, finally, Mr. Chairman, is there a plan to disseminate this report once the final copy is done? And who could it be made available to? Could this whole group receive a copy that's not part of the packet?
Yeah, I guess I can speak to that. Absolutely, it will be disseminated to the group, and I think we might make it available to the public as well, but absolutely everyone here will receive a final copy.
Although we want to be as transparent as possible, sometimes we have some limitations in what we can do to all of our citizens.
Yeah,
as well.
post it on the
Right.
website.
Thank you. So, thanks, Jesse. We'll move on now, if we have no one else. Let's go ahead to item C, an update on the NACO Leadership Network from Board Member Susan Schaefer.
Thank you. As you know, at their last meeting, you heard about a profile that NACO did about my coordination or championing cross-systems coordination and collaboration. Well, a couple weeks after that, I was informed that I was named to the initial cohort of the Familiar Faces Leadership Network from NACO, which is 13 city or county leaders from across the country. The purpose of the Leadership Network is to strengthen, this actually kind of really ties into some of the stuff we've talked about today by Mr. Block and Mr. Siegler-Walls, I got to get that right. The purpose of the Leadership Network is to strengthen and expand McLean County's ability to share cross-system data to identify familiar faces and improve outcomes by developing strategies to align data from justice, health, and human services systems. So it's pretty much that transformational type of thing that is in the report here. The other thing is program development. And so like we have a FUSE program, so we're going to wanting to enhance that because we also realize that we don't have some of the data and we believe that we're missing some individuals to be part of that program. So what is going to happen is that there are going to be 3 technical assistance calls and 2 site visits I'm going to be part of that. And the technical assistance calls, we focused on the legal, which we just talked about with the BAAs and the MOUs and things like that on data sharing and programming, and they should be completed by the end of the year. And the site visits are going to be to communities that have model data sharing practices. And all of this is paid for by NACO with generous support from Arnold Ventures, who we've worked with before with the Corporation for Supportive Housing for our data matching tool, which only matches homeless data and justice data, not health data. And so I've asked to be on the agenda for the next 3 BHCC meetings to provide updates for the TA calls, which should be done by the end of this year, and then the site visits. I think the first one is going to be sometime in January. So that way this group can be informed as to what we are learning and what kind of assistance that we're going to be getting and how that's going to impact some of the things that not only are in this report that we've heard about from Tri-West, but there's numerous recommendations in the Mental Health Action Plan that will be touched on by some of this stuff too. Actually, in some of the considerations in the Tri-West report or in the Mental Health Action Plan. So if you have any questions about what I'm going to be doing with that or anything about the Leadership Network, see me after the meeting, please. Thank you.
Okay, thank you, Member Schaefer. Let's go on to our program initiative updates. First of all, FUSE, McLean County program update.
Yeah, so Nicole, you're off the hook. I'm going to do the update for you, but our program supervisor is here today. A lot of our figures haven't changed since last reporting for FUSE. You will see a couple of the infographics we have in here highlighting a little bit better what FUSE has going on right now. I think the biggest update that I want to provide to the individuals in this room is that in conjunction with our EMR implementation, we're reassessing the self-imposed criteria that we have for our FUSE program, and we're hoping to kind of expand in some ways by lessening that criteria and allowing more individuals into Fuse over the next few months and year. We hope to grow that program and get more individuals linked to Fuse. We've been incredibly successful, I feel like, now that I've been in this position for a bit and been more in tune with Fuse and been able to see the team that's running that program. I just want to say how incredibly proud I am of the work that they're all doing. It's a great job. Any questions related to Fuse? Okay.
Sounds good. Let's move on.
All right, let's move on. The McLean County Triage Center. I'm proud to say if you look at our figures on here, June was actually our busiest month. We had 125 client interactions during that month. And if you remember the data that we saw in the presentation here that showed around 300 client interactions over the entire year of 2021, our quarterly numbers are getting close to meeting that. And so we're looking at close to 300 to 400% of the amount of clients that we did in 2021. So we've had really great success with that. Our number of repeat clients is down over this period as well, which shows that we're resolving more of these issues. So I'm extremely excited about the work that we're doing. Do we have any questions related to triage?
Do we know why we're having such increased flow?
So I would say towards the tail end of Vanessa Granger Belcher being here, she did a great job of reaching out to community members and also providing time for myself and also Nicole Kirstein to go out and promote our program, speaking more with law enforcement, engaging our Law and Justice Center a lot more, doing tours of the Triage Center. And I think that all of those things combined definitely culminated in getting more people's attention when it comes to the Triage Center, just getting that word of mouth out there more. You'll also see during this quarter we had a slightly higher amount of law enforcement drop-offs, so I think that they know a little bit more, at least maybe in some silos, about the Triage Center and are more frequently bringing clients to us. Any other questions? Okay, and then the third thing on here, Cure MD EMR implementation, I just wanted to put that on there so I could brag about it a little bit. We are in the middle of our EMR implementation, which has been a long time coming. We struggled with some other EMRs that couldn't fulfill our needs in the past, and I'm happy to say that so far during this implementation, CureMD has been excellent. And we're looking for a go-live date before November 1st. That might be a little bit ambitious. I know some things, with our scheduling might push things back, but that's the date that we're looking at right now, and I was very pleasantly surprised to see that we could get that off and running so quickly. Any questions related to our EMR implementation? Quiet bunch today, huh? Thank you for hanging around, by the way. I know we're kind of running long today. If I could, Taylor, could I have you come up and just do a quick update related to forum stuff as well as RISE? As she makes her way up here, I'd like to say Taylor Davis' last day with the county is going to be next Tuesday. And I would like to also all to show her our appreciation for what she's done for RISE, for the forum, and countless other projects. So if we could give her a round of applause real quick, I'd appreciate that.
Thank you, everyone. It's been a pleasure working with you all, and I wish the best for the county's efforts in behavioral health in the county. As far as RISE, RISE is still doing really well. The first two products are completed and are in your packet. The logo has been decided as well for the initiative, and so that is also in the memo. Meetings are continuing, and goals are on time to be met for this year that were set at the beginning of the year with the core team. Including a web page to be up by the end of the year with some resources. So super exciting for that. This month's core team meeting, they started brainstorming what they want to do as far as pushing out to the community in September as well. Piece for Tarpon from Tarpon Springs presented at our September core team meeting, and then they recognized us on their Facebook page, which I hope to share through our county page soon as well. So good things happening with RISE, and I hope that continues that momentum and engagement. As far as the forum, the registration has opened as of last Friday, and as well as the volunteer sign-up sheet. Hoping most of you can try to volunteer for at least one slot. And the flyer is in your packet as well. And so there's a link with a QR code for the registration. But I'm happy to take questions on the forum or RISE. All right, thank you.
Thank you.
Anything else you have?
No, that's it for us.
Okay, let's go ahead. Next meeting date, special meeting, October 14th, has to do with youth. I think a number of things have been pointed out through the report on that. So hopefully get everybody here together, get our heads together, see what else we can do, and focus on one of the needs that was identified in the advanced, the plan and the revised plan, mental health action plan, and we're still not there with what we need to get done. And so we know that's going to be important. Our regular meeting is going to be December 9th. We'll try to limit these meetings so that they don't drag on quite so long. We had a lot of important information to get out to everyone today. As we finish this meeting, I think we can maybe try to consolidate more because everybody here can check and read reports. Maybe we can put it into a consent agenda and just have questions answered for that, and we can reorganize a little bit better to save on time with that. Last meeting ran over primarily, and I want to apologize for that a little bit because I was trying to incorporate public opinion into our BHCC meetings because the same speakers that came to county board were requested by one board member to speak again. I think there's a point in time, though, and I hear this word transparency all the time, that we have to meet and decide and work with what we're doing here. You can't involve everybody in the public. You can't have every worker from every organization. That's why you're in charge of the organizations, and that was the idea and the concept of why we came here, got our heads together. If we wanted to open up to have a public meeting every time and have a hearing and have speakers, that's what happened. So it is my fault for that. I was trying to show and encourage some kind of transparency as we went through that. I think governments and politics sometimes get mixed up a little bit. We have certain people that are elected, like myself, who are politicians here, and they want to bring in things and do some things. But I don't think we need to be self-promoting in what we're doing because we're all here for another reason. The question is, how much is governance involved in all this? Where do we stand with this group? And I think that's something that I think Jesse's pointed out. I think it's something that we all need to take a look at as we move forward. I want to hand out something I ran across. I thought it was kind of talked a little bit about governments and politics. You can point out some issues we have. I have this in my office as a reminder to me that there's times when you need to be working together and be legislators and in governance and not politicians. And so something I thought you might be interested in, so I thought I'd hand it out at the end of this meeting. I thought it was appropriate. And I have nothing else. Anyone else? If not, well, thank you all for coming. Thanks for your patience. Thanks, Jesse, for your report. Really appreciate it. And we'll continue to work and follow up and help the people in this county best we can with our behavioral health situation. Thank you.
May I provide one brief update?
After the meeting's adjourned? Sure, hop right in here. Yes, that's a yes. Can you hear us?
Yes, thank you. I just wanted to let the group know, we've spoken briefly about the Pathways to Success program that the state will be putting out, which will bring wraparound and high intensity care coordination for youth who are Medicaid eligible to the state and McLean County. I did want to share that we are going to be the Pathways provider. We were given that role, and I look forward to sharing more information as that comes out about what that will look like and how that will interact with everyone.
Okay, thanks.